Hi there, I'm Sujata, founder of Grace USMLE Tutoring. I partnered with Achievable to create a comprehensive USMLE Step 1 course for medical students. It combines my years of USMLE tutoring experience with Achievable's powerful software. To learn more and gain access to a free trial, visit achievable.me. Hello, I am Sujata. I am the founder of Grace USMLE and USMLE author at Achievable. In this video, we will talk about acid-base disorders. Acid-base disorders are caused by abnormal changes in the PaCO2 or the bicarb levels, and they are often accompanied by changes in the blood pH. To understand the acid-base disorders, we need to memorize a few normal values on the arterial blood gas analysis. So these include normal arterial pH, which ranges from 7.35 to 7.45, normal PaCO2, which is the partial pressure of carbon dioxide, which ranges from 35 to 45 millimeters mercury, and the normal bicarb level, which ranges from 22 to 28 milliequivalent per liter. There are four primary acid-base disorders. Those are metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Let's look at each of them one by one. Metabolic acidosis is caused by an abnormally low level of bicarb in the blood. It can be of two types, depending on whether the anion gap is normal or it is elevated. Anion gap is nothing but the difference between the cations and the anions in the blood. The formula to calculate anion gap is concentration of sodium minus the concentration of chloride and bicarb. Normal anion gap is between 10 to 14 milliequivalent per liter. Increased anion gap metabolic acidosis is characterized by an anion gap that is higher than 14. It can be remembered by the mnemonic mud pilers. Common causes of increased anion gap metabolic acidosis include renal failure, diabetic ketoacidosis, and ethylene glycol poisoning. In normal anion gap metabolic acidosis, the anion gap stays within the normal range of 10 to 14 millimole or milliequivalent per liter. Common causes include diarrhea and renal tubular acidosis. You should remember all the causes of renal tubular acidosis. Major among them are aldosterone antagonist and acetazolamide. Metabolic alkalosis is characterized by abnormally elevated bicarb levels. Common causes include hyperaldosteronism, Conn's syndrome, where there is an adrenal adenoma, prolonged vomiting, and thiazide or loop diuretics. Respiratory acidosis occurs because of carbon dioxide retention, mostly because of any reason that leads to a decreased respiratory rate. The PaCO2 or PCO2 levels will be higher than 45 millimeters mercury. Common causes of respiratory acidosis include opiate overdose, morbid obesity, sleep apnea, and complications seen in asthma, COPD, and respiratory distress syndrome when the respiratory rate decreases. In acute respiratory acidosis, the serum bicarb level is equal to or less than 30, whereas in chronic respiratory acidosis, the bicarb level is more than 30. Respiratory alkalosis is characterized by an increased respiratory rate, which leads to reduction in the PCO2 level to below 35 mmHg. Common causes of respiratory alkalosis include high altitude, pregnancy, and aggressive mechanical ventilation. In acute respiratory alkalosis, the bicarb is more than 18. In chronic respiratory alkalosis, the bicarb is between 12 to 18. Let's talk a little bit about compensations in acid-base disorders. Whenever there is a primary acid-base disorder, the body tries to compensate to bring back the arterial pH back to normal, and that's called as a compensation. It is always exactly opposite to the primary metabolic disorder. For example, if the primary metabolic disorder is a metabolic acidosis, the compensation is exactly opposite to it, which will be respiratory alkalosis. On the other hand, if the primary acid-base disorder is metabolic alkalosis, then the compensation is going to be a respiratory acidosis, and so on. Full compensation of an acid-base disorder almost never happens. If that is the case, then the compensation is able to rectify the pH and bring it in the normal range. However, partial compensation is seen a lot of times. To understand the degree of compensation that has happened, we need to use a few equations or formulas. The formulas to calculate the expected compensations are on the slide shown. Let's take the example of metabolic acidosis. Winter's formula is used to calculate the expected compensation in metabolic acidosis. So let's revisit this. When the primary disorder is a metabolic acidosis, you expect the compensation to be a respiratory alkalosis, which means the compensation is going to decrease the observed levels of PCO2, and that's what we are trying to calculate in the Winter's formula. Winter's formula states that the expected PaCO2 is equal to 1.5 into bicarb plus 8, and the range is plus or minus 2. Let's take an example of an ABG for metabolic acidosis, where the observed PaCO2 is 42 and the observed bicarb is 20. Putting the level of bicarb in the Winter's formula, we can calculate the expected PaCO2 in this example to be in the range of 40 to 44 mmHg. Our observed PaCO2 in the ABG is 42, which is in the range of expected PaCO2 that we calculated by the Winter's formula. So that means this is an uncompensated metabolic acidosis. Suppose the observed PaCO2 in the ABG was lesser than the expected range. For example, the PaCO2 observed was 35 mmHg. Then that means there is a respiratory alkalosis, which is the expected compensation for metabolic acidosis. And your diagnosis will be a partially compensated metabolic acidosis, since the pH is still not in the normal range. Let's take another scenario. In the same ABG, if the observed PaCO2 was 55 mmHg and you are expecting your PaCO2 by Winter's formula to be in the range of 40 to 44 mmHg, then what you see on the ABG is definitely an elevated PaCO2. When that happens, it means there are at least two disorders of acid-base metabolism. In this case, since the PaCO2 is higher than expected, the disorder that is present along with the metabolic acidosis will be respiratory acidosis. Sometimes when multiple acid-base disorders are present, the pH may be normal or even very close to normal. In that case, we know there is an acid-base disorder because the values for bicarb and PaCO2 will be abnormal. So by using the formulas for expected compensations, you will be able to know whether the acid-base disorder is uncompensated, partially compensated, or if multiple disorders are present in the same patient. Hope this video helped you understand the concepts in acid-base disorders better. Thanks for watching.